So in the second online seminar of the Glasgow Anthropology Network, we have with us Stefan Ecks. And Stefan Ecks is a senior lecturer in medical anthropology at the University of Edinburgh, where he co-founded the medical anthropology program. He conducted fieldwork in India, Nepal, Myanmar, and the UK. His recent work explores the concept of value in global pharmaceutical markets, changing ideas of mental health in South Asia and multimorbidity. His publications include Eating Drugs, Psychopharmaceutical Pluralism in India, with New York University Press, and the forthcoming monograph, Living Worth, Value and Values in Global Pharmaceutical Markets, Duke University Press, if I'm correct. Stefan is also, I should say, a long-term friend and a mentor, so it's particularly nice to have him with us today. So, but before we start, Stefan, let me ask you, how are you doing and how are you coping with this pandemic?
Yeah, thanks, Diego. I'm doing quite all right under the circumstances. Yeah, so particularly today is very sunny outside, and it's still possible to go outside, which is not even the case when you're in India, for example. You can't even go outside for exercise, for example. So yeah, under the circumstances, it's all right.
Fair enough. I mean, yeah, it's incredible. It's the sun in Scotland when we are in a lockdown. Anyway, I'm intrigued about the title of your forthcoming monograph. And I've also noticed that theories of value are becoming an important focus in your recent work. What does valuing health means, especially after the corona shock?
So yeah, the book is about, trying to develop a new theory of value, which really captures both kind of what's usually seen as commensurable economic value on the one hand and incommensurable ethical and cultural values. Can you see the next slide?
Yes.
Okay, good. So, and I'm particularly interested in thinking through life, basically. Life as often appears to be the highest value, basically, and it's usually also seen as what's most incommensurable, as something that should not be exchanged, bought, and sold in any kind of way. So it's what life kind of resists its, being turned into a commodity in a market, and yet, of course, life is being commensurated and valued in an economic sense all the time. So I'm really interested in value and life and the value of life, and I'm trying to come up with a theory which really captures both the commensurable and the incommensurable. And so I'm kind of starting with Graeber's theory of value, who kind of said that it should be possible to come up with a unified value theory that links everything together and makes some kind of symbolic system, as he says, that defines the world in terms of what is important, meaningful, desirable, or worthwhile in it. And one of the key points that I'm developing in the book is really an embodied value theory. So it's about trying to understand life as embodied life, and also embodiment as the source of all forms of valuations. So much of the book is really a sort of social life science, really sort of developing a social life science based around the notion of value and trying to overcome this distinction between the incommensurable and the commensurable. So just to give you an example for this also, and something that I'm gonna develop further now with the coronavirus shock, just a simple example, saying also that how do we establish value? Where is this coming from, and what is it exactly? And the whole book is about showing value as a social process. It's something that's negotiated in social settings with people coming together and basically negotiating what the value is of various kinds of items or actions or events. And to give you a very easy example, the loaf of bread, right? And the question is, would you be willing to pay £2 for a loaf of bread? Is it worth £2? So also ultimately you have to live, and in order to live, you have to eat. So there's some value in eating bread. So there's a value also, there's something there that makes it worthwhile for you to spend £2, but it's still the question, is this the best way you can spend your money? Is the bread giving you the most value for life? All of these questions. And what I'm distilling from these social processes is a list of criteria that come into pretty much all of these negotiations of value. So these are mutual recognition between the partners of any kind of valuing exchange. So A and B as someone who is selling the bread, and B is someone who is buying the bread. So there's the question of mutual recognition between them, the question of trust, transparency of the transactions and what's being transacted, the level of routinization, the levels of institutionalization, expertise, and technological elaboration. So when you look at the bread, it's really something that is fairly straightforward. For example, you go to a supermarket and the bread
looks nice. You kind of trust that the brand that you've always been buying of bread is something that doesn't have any nasties in it, and that you're not going to die after eating it, right? So there's a high level of trust probably there, but of course, as we know from anthropologies of food, this trust can very easily be disturbed. Also, transparency is another straightforward thing, but it can be disturbed, and so on and so forth. And with the bread, you have a very high level of routinization, and also to some extent, institutionalization, but also expertise in terms of the actual you buying the bread is very, very low, right? And the technological elaboration, you could also say, is pretty low. There's a lot of expertise that is required for manufacturing the bread, but it's, the actual transaction of you buying the bread doesn't require a lot of expertise nor technological elaboration. And this is sort of the model. So I've been revising the book. The deadline for the submission of the manuscript is just around the corner, but I really wanted to include something also on the corona shock. And of course, this is a moment where the question of how you value life, particularly in a medical domain, is absolutely vital. I think this is I didn't know that corona shock was coming, obviously, when I started writing this book, but I think it's just insanely important to think about these questions of the value of life at this particular moment. And so I've been revising some of the book also towards and taking in what's been happening in the last few weeks. It's really just weeks and not even months. And one of the cases I'm looking at now also is the lockdown as a particular biopolitical intervention, which has been enacted by many countries around the world, because also it's the only viable option, it seems, at the moment to do anything against the coronavirus spread, because we don't have any pharmaceutical treatments yet, right? There's various attempts to do something, but really there's nothing yet established that once you have the virus, that there's a drug or a combination of drug that could help you in this way. And there's also obviously no vaccine against it. So biomedicine is also actually reduced at the moment to just interventions on the level of emergency care, right? And even, contact tracing in these various testing regimes are there. But also this has already run into these major difficulties, as we all know, particularly in the UK, where there is such a lag in people, in the rate of people actually getting tested for this. So the lockdown has become really the global phenomenon of dealing with the coronavirus. And the question really is, first of all, okay, and I find this really striking in all of the discussions, that often it's not enough distinguished somehow, sort of what is to be done about the coronavirus as such, and how does it spread, and how is it infectious, and so on, and to really set aside this phenomenon of the lockdown as such, right? It's a very intricate phenomenon that has become sort of the new normal, or as if there's no alternative to it. But it's very important to, first of all, think of the lockdown as something it's a really a new phenomenon also, and what exactly is entailed in this lockdown and what measures are taken. And you have lockdowns in all varieties and degrees of, some of them are advisory in some countries, some parts, some are mandatory, and the exact combination of what is being done by different countries in terms of lockdown also varies a lot, right? So you have control of physical contact, border checks, travel bans, quarantine measures within the house or outside, physical distancing, closing of workplaces, educational institutions getting closed, canceling public events, public transport, and then questions also wearing face masks and maybe other protective gear as well, right? So the lockdown as an intervention actually is very blurry, because we don't even know exactly what is entailed in each case in each of these countries that are enacting them. And so the lockdown is basically open to the question of how valuable is it actually in terms of saving lives, right? We want to save lives, but the lockdown comes at an enormous cost, right? And one of the ways of it, it's basically really a commensuration between saving lives around the world, but also disrupting the economy to such an extent that the poverty and the hardship that will come from this disruption will also kill a lot of people. So the lockdown is not a little remedy that comes without side effects. There's enormous side effects. And the question is, what do we know about the side effects that are coming from these lockdown interventions? And when you look at COVID-19 in these value questions that I sort of, in the book, I'm looking at this more broadly with different kinds of pharmaceuticals, but you can also apply this to COVID-19, and then the question, for example, of the lockdown measures there. So you can see that the recognition question between A, in this case, you could say is a government, and B, are citizens, is there. And then you could say, well, there's actually, in some countries, there's a very high level of recognition for the lockdown measures. In other countries, there's very low levels of recognition for that. And the more recognition there is, the more people are actually pulling through with this. So I see some very strong differences, for example, in terms of recognition from citizens between the UK and in Germany, because in Germany, people are, although they've been doing so much better there, but Germany is, people are far more critical of the lockdown interventions as such, and give less recognition to it. Then there's a question of trust, in this case, again, between governments and between citizens. And there's a lot of evidence that more trust is definitely far better for the enactment of these measures. Transparency is a major issue. So the more transparency that governments had in terms of communicating what these lockdowns are and what they're for and what they're meant to achieve and so on, those seem to be more successful in enacting lockdowns. And New Zealand is often cited in this regard as as a model for how you should, as a government, should actually communicate in a transparent manner what the lockdown is meant to do. And then finally, these questions about routinization, institutionalization, expertise, and technological elaboration, because those really, really struck me as something just really lacking, basically. There's something very strange going on at the moment. And I call this just a pandemic of epistemic unpreparedness. When you look at the World Bank, International Monetary Fund, but also, of course, we hear most from the World Health Organization. And there's a question also of if the World Health Organization shouldn't have been better prepared for all of this. But actually, there's also a question of what about the World Bank and International Monetary Fund and these major organizations that are looking after the financial health of the world, if you like? And what really struck me about the lockdown measures is that all of these institutions and all of the experts in these institutions were completely taken by surprise by both the spread of the coronavirus, and they were also completely taken by surprise of the lockdown measure itself. They had no, in all of the scenarios that they were playing in terms of pandemic preparedness, apparently the notion of a lockdown never ever appeared, which is unbelievable in a way when you look back to it now. And also there's absolutely zero preparation for how would we actually value the impact of the lockdown? You know, what's the cost effectiveness of the lockdown measures that we're enacting, and are the lockdowns not costing more lives than we're actually saving? So, for example, also in going back in the history of this, in January, the WHO representative to China said that when China enacted the first, the Wuhan lockdown, which started all of this in January, the WHO said the lockdown of 11 million people is unprecedented in public health history, so it is certainly not a recommendation the WHO has made. And you find an enormous resistance to these lockdowns by UK government and the US government famously. Boris Johnson, just yesterday, we heard that he was saying in February that the UK is not gonna go for any kind of lockdown because that's sort of just for some totalitarian regimes, and him saying something like that the UK will be the supercharged champion of the right of the populations on earth to buy and sell freely among each other, no matter what, basically. So stay open for business and all that. We're not going to get sidetracked by any of that. And of course, though that attitude also has probably delayed the response and the preparedness very, very badly. But again, also absolutely no notion of what is this action, this lockdown that is happening there, and how could we understand the effects of this
Stefan,
lockdown there?
I have to interrupt you here, unfortunately, because otherwise, we won't have time to address, the remaining question. But that sounds fascinating. So let us move to something more general, which I think, is quite interesting inside of conversation we have had. A few eminent academic and non-academic voices admonished us that this isn't quite the time for philosophizing about life and death, health and society, and asking those kind of big questions, and intellectuals getting involved in this discussion. And I know you disagree with this, and so do I. Why do you think that social anthropology has the potential to shed some light on the complexities of this pandemic? And what do you think anthropology's unique contribution can be? Try to keep it down to 5 minutes, please.
Yeah, this will be much quicker. So yeah, I think this is also just an extremely interesting moment for anyone who's doing research generally, right? Obviously, the medical research is extremely valued at the moment, but also epidemiology and public health research. And then you have the social sciences, and anyone who's doing anything that's applied in that field also suddenly, I also felt so much more compelled to think about this and to write about this than before. And you have this massive outpouring of blogs and discussions, and so also from the social sciences, people writing op-eds for newspapers, for example. So this is a really, really amazing moment in a way for anyone who's doing this applied research. But then there's the question of, there's a lot of people also who are doing non-applied research, more theoretical, conceptual research. And some people have said that, yeah, there's, what's the point of that now? We don't need any theorizing about that. Or I've seen this meme also going around the internet, sort of, you do not, no one does, what was it called? the Lord of the Rings character, and one does not simply theorize in a pandemic, right? So as if theory is just the worst thing you can do, it's a waste of time in a moment that is so full of urgency. And yet you could say that some philosophical things also that have been said seem to be a bit pointless, or do we actually need to know what Heidegger was saying about being towards death, for example. But I kind of really think also that this much more conceptual theoretical work is probably as important as all the applied work at the moment as well, because there's such a, again, going back to this point that I made about this epistemic unpreparedness, that this what we are seeing. So we see on the very large institutions that should have been prepared, this high level of unpreparedness in an epistemic kind of way. And we see it across the board, really. And I think that really this is also a moment where you just need to work very hard on your concepts also, and how we conceptualize, for example, the question of value and the value of life, and what do we even mean by value. And so to that extent, I think that conceptual work is extremely important. In fact, it's almost the only thing, because we don't even know what this moment actually will look like also in the near future or in the long run. So I think it's a supremely important moment specifically for conceptual work from the critical social sciences. And so I've also written about, for example, again, Foucault and the question of biopolitics, and what we are seeing is a turn towards biopolitics, then what kind of biopolitics is it? So a lot of the conceptual work, I think, is extremely vital at the moment.
Okay, that's fascinating, because it also raises concern of what kind of academic expertise within our university is going to be valued in the imminent future. That's a concern. I mean, we have in terms of funding, in terms of employment, who knows. But yeah, I want to take you somewhere else. You've written a blog post in Somatosphere where you suggest that we should look more closely at the medical histories of COVID-19 patients, and specifically COVID-19 victims. I found the explanation you have there quite intriguing, and also slightly unsettling. Why should we look closely at these histories?
So yeah, what I've done, this is from another research project that I've done over the last few years, which is in an NHS clinic in Scotland. This is where it's actually based on. So there's an integrated NHS clinic here, and they basically, this is set in one of the most deprived areas of Scotland, right? Think just the lowest indicators for, not just for health, but also for income, for education, for you name it. This is a very, very deprived area, and there's this integrated health clinic. And in this area also, they have a life expectancy of just 62 years, right? Which is on par with Zimbabwe. So this is incredibly bad in a way, like also hidden forms of social inequality. And I was working with people in the clinic basically, and also looking at what kind of health problems people actually have when they come to the clinic. And what struck me from these observations in the clinic is really the level of people suffering from several chronic health problems at the same time. So the term for this that's used in the medical literature usually is multimorbidity. So it's not just one chronic problem, but 2 or 3, or in the case of this particular clinic, people usually have 5, sometimes 10 chronic health problems at the same time, and physical health problems, mental health problems, all mixed together. You have very typical that people are suffering from depression, diabetes, obesity, high blood pressure, lots of digestive problems, often a whole cluster of problems that just don't seem to respond to treatment all that well. In actual fact, this is the sort of other side of that story, is when you look at the treatment histories of those patients with chronic health problems, what you don't see is a lack of access to healthcare in a way. What it shows is that they've all been in treatment for many, many years, and all of them come to the clinic or in the clinic having been literally bombarded with different kinds of drugs. So one drug or two or three to deal with blood pressure, and several drugs for the diabetes and the antidepressant, and. So it is an enormous consumption of pharmaceuticals going on in that clinic. And also being in that clinic for quite some time, it's very obvious that the patients do not get any better with this. I mean, if anything, they seem to get worse, right? And the GPs also who are working there, they kind of recognize this, but at the same time, they don't really know what to do about it necessarily.
So what's the connection with coronavirus deaths?
So the connection there is, so basically I've been doing this work, and then I noticed that with the coronavirus, suddenly everyone's been talking about these underlying conditions, because the coronavirus seems to kill people with several chronic health problems first, or they seem to be most at risk, basically. So it's a question also of, can we understand multimorbidity much better? And then I kind of just took this one step further and asked, okay, what I've observed in this clinic is that we're not just looking at multimorbidity, but we're also looking at chronic medication use and possibly harmful side effects of this chronic medication use. And that's why I wrote this blog saying, we don't just need to understand much better what the multimorbidity patterns are of COVID-19 victims, but we also actually need to look urgently at what their medication histories are. That was the link. And sort of one of the links that came up there was suggested by this Dr. Anthony Fauci, who is the Donald Trump's main scientific medical advisor.
Main enemy.
Sorry?
Main enemy.
Who?
Enemy.
Yes, of course. But basically, Anthony Fauci also saying, oh yeah, I noticed that there are these ACE inhibitors that the patients in Italy, where of course coronavirus hit so hard at the beginning. So basically, we're picking up on the fact that it's not just people who have high blood pressure are disproportionately killed by the virus, but also that a very large number of these patients are on these ACE inhibitors. And he was just sort of tossing this around that, well, maybe there's actually a link here that we should consider, which is that, maybe it's not the high blood pressure that kills them, but it's actually the medication intake that kills them. So this is what this blog post was about, and trying to get this on the cards. And of course, again, within the sort of this urgency of this moment, this got kind of lost entirely, right? So we need to save lives. We don't have time to even look at ethnicity profiles properly in the UK, for example. And this question also of taking the time to look at what kind of medications are the people who get killed by the virus. No one's taken the time for it, but I think it's potentially extremely important to look at that.
So let me interrupt you here. That's very interesting, because essentially you are saying that we know very little about the interaction between different drugs, and how the fact that you're taking different drugs for different conditions at the same time might or might not make the COVID infection worse. And that's quite interesting here, because there is also a link to your recent work on iatrogenesis, where you describe how some medical interventions, say the prescription of a given drug, might rapidly trigger a cascade of other treatments. So could you describe how this happens concretely and what the consequences are?
So yeah, again, I studied this quite at length for my first book on eating drugs in India. So I was also really, really interested in these notions of people over-consuming drugs, taking drugs for too long, in the wrong kinds of combinations, and then suffering all sorts of ill effects. And I think that the awareness of these bad side effects is something that is far, far clearer even in India than it is in the UK. In India, really, this is the number one concern that people are expressing. It's like, oh, there's this drug, but what's the side effect profile, and how are these drugs interacting with the other drugs that I'm taking? So the concern about side effects is very strong. So I wrote a lot about that in India, and then with the recent project in Scotland, also, the clearest cases of these cascading ill effects of iatrogenic side effects are whenever people actually undergo surgery, right? So also from this NHS clinic, there's a lot of cases of people who underwent some sort of very drastic surgery, for example, some bariatric surgery to remove parts of their colon, and then in the process there were cases, for example, of women having their uterus removed, and the removal of the uterus obviously then triggered the onset of menopause, and the menopause with all sorts of hormonal imbalances, and then that triggered depression, and it constituted trauma in itself. So this was something that came up there in with surprising frequency, I would say. But also, of course, these other things that are there. So you go to a doctor, and then he puts you on one drug, and then that interacts with something else, and that gets then the side effects get plastered over by another drug, and those get treated then as well. So you end up with a scenario of people just getting consuming loads and loads of different drugs and not getting better necessarily. So
here you're describing, Stefan, some scenarios in some cases in which the cure, or the cures might create greater harm than the disease. I mean, that reminds me also of the etymological origin of the word, pharmaceutical. But anyway, this is theoretically fascinating and pragmatically really depressing. I was wondering, if you could give us, a concrete example of this dynamic, and please remember to keep it brief because, time is running, let's say 3-4 minutes.
So again, I'm going back to, maybe it's useful just to this other slide there, which is about the multimorbidity. This is from a study that was one of the most cited studies on multimorbidity, which was actually conducted in Scotland with NHS patients. And what they found in this 2012 study is that about a quarter of all Scottish NHS patients are multimorbid, and there's more among women than among men. There's a lot of comorbidity, multimorbidity with mental health problems there. And just to go back basically to this point about what's the link to socioeconomic deprivation, which is what they found is that multimorbidity sits on up to 15 years earlier in areas of socioeconomic deprivation among the patients there than in richer areas, or the average. This is compared to the average. And this is, I think, such an incredibly important feature also from, again, sort of helping me to understand why I was seeing people in the Scottish clinic in their 30s, for example, with these 5 or more chronic illnesses at the same time. And again, them being on these medications for such a long time, because there's this pattern of basically socioeconomic deprivation moving the onset of multimorbidity forward in their lives. And so, you have all these ill effects of over-treatment anyway, and uncoordinated and non-integrated biomedical care. but it gets particularly worse in areas of socioeconomic deprivation, basically, because there you also have a much higher level of multimorbidity among the people there.
Okay, so we have 10 minutes, so let's try to keep it very brief. I wanted to stay on the topics of pharmaceuticals, and I've noticed that the issue of overprescription is a recurrent theme in your recent work. I wonder if you could just tell us something more about its UK-specific institutional and cultural roots, and also if you foresee any solution to it.
So what's interesting in the UK is also, first of all, of course, a very strong dominance of biomedicine, as we say in the social sciences, or just orthodox general medicine. You probably have this, particularly strongly here. Like, of course, there's a lot of medical pluralism as well, but biomedicine with the NHS, of course, is very, very strong. And again, me comparing India, where medical pluralism is so much stronger, to the situation in the UK, this biomedical model of thinking that there's one particular disease, and then you have one particular drug that fights this one particular disease, and all you need to do is clearly identify the one disease that's there, and then give the one drug that actually takes care of this. So there's a very deeply entrenched model, which you don't find quite to the same extent in India, for example, which has a much more, still also among patients, a much more humoral pathology idea, of flows and balances, and illness as an effect of imbalance, which just doesn't allow you to come up with the same level of certainty that what needs to be identified is one particular disease, and that gets shut down by one particular drug. And so that's kind of one difference there with the UK. And the other very important one in the UK is that with the NHS, you have very easy access to biomedicine in a way that you don't really have in India to the same extent. In India, you still have to pay out of pocket for almost all of your medical treatments, and poverty is a major barrier to even seeking help in the first place. And in the UK, a situation such as what I then ended up calling polyiatrogenesis, which is this multimorbidity pattern deepened by an chronic overuse of these different kinds of drugs. Again, sort of this was such a striking feature of working in this particular clinic in Scotland, and it comes from a combination of having to do with the economics of accessing health, of the predominance of biomedicine, and with that also that it's very easy to get overtreated in the UK. It's also happening in India, but I think it's probably happening in the UK even more so.
Yeah, I was thinking it would be interesting also to have a comparison, not between, a medical pluralistic system like India and one where biomedicine is dominant, but also, between countries like, the UK, Germany, or Italy, that are still largely dominated by biomedicine, but nevertheless, there is perhaps a different approach to lifestyle and well-being. I don't think we have time for that. I just wanted to ask two questions, very brief ones, so let us keep the answer brief too. And the first one comes from my anxiety, perhaps. The current pandemic is a fast-changing crisis, right? In which our assumptions are constantly overturned by disorienting discoveries and events. This happens on a daily basis. We thought we knew something, we don't. Let us rethink it and rethink it quickly. And with that come also a certain epistemic angst. What are we? What should we believe? What's the truth? What counts as true to full information? What doesn't? So having observed the recent developments of the pandemic, And have your view changed since you wrote the piece in Somatosphere?
Yeah, that's a really interesting question, because I also experienced the time of Corona shock as very peculiar. You know, on the one hand, it seems like as fast-paced as nothing before, and at the same time, we're all stuck in this motionless lockdown situation. So it's a very, very curious time. And yeah, it seems that things are changing so fast, and yet at the same time we still know so little about what's actually happening, you know. And of course that kind of keeps me glued to the news and Twitter and Facebook all day long, as well as I was just sort of trying to catch up with all the things that are actually happening. But you know, the level of lack of clarity about what's happening. So I'm also, of course, watching very carefully what's happening in India, and I'm very interested also in whether, you know, India with its 1.3 billion people to date has just over 500 recorded cases of death from coronavirus, which is amazing in a way, right? And of course they have a lockdown also in place, which of course, as I also think, has an enormous terrible side effects there for, you know, pushing a lot of people into poverty. You know, some projections are there that it really will throw India back in terms of poverty by 30 years or so by what's happening. And it's the lockdown that does that. It's not the coronavirus, it's the lockdown that does that. So, you know, watching very carefully how the numbers are unfolding basically, and also looking very carefully at how the global south is faring in this, because again, sort of one of the possible, I'm looking at this world map, right? This world map of the spread of the coronavirus. And what is so striking about this world map to date is that it's Western Europe, rich Western European countries and the United States, which are far, far more severely hit by that. And at the beginning, again, sort of in this fast changing mode, it was said like, oh, that's just because they test much more. And it's because people are seeking care. And, you know, that's why we see these numbers there. And just wait a few more days and you'll see this explosion in African countries. You'll see this explosion in South Asia. And yet it hasn't happened yet. And this is what I'm kind of holding my breath on also, is that are we actually going to see such an explosion of cases in these other countries, or will it kind of stay as flat as it is at the moment? And of course, I very much hope that it will stay on this very flat level. And, you know, again, there's this possibility, and we'll know maybe in a few years' time it will percolate, you know, whether again, sort of certain kinds of regimes of chronic uses of medications, which might be more entrenched in Western Europe and in the United States, might be partially to blame for what we are seeing at the moment. And, you know, that's a real possibility.
I was thinking, you know, when you were speaking about this sense, you know, everything is moving so fast and yet we are stuck and, you know, living so slowly. That, you know, that there are so many aspects of this pandemic that haven't received a lot of attention. One is precisely, you know, the phenomenology and temporality of this paradoxical experience of frantic immobility or frantic stillness, and the ways in which, you know, we're exposed to a rapid flux of information and the slow-paced, the slottish life in pajama. But anyway, that is just, you know, to ask the last question, which for me is really, what in your opinion the issues related to the pandemic that are not discussed sufficiently can be at this moment? What issues do you think, you know, need more attention?
I mean, again, sort of for me, what's, first of all, going back to where we started, is this question of how do we value life, and the way that we value them, how can we make sure that certain lives are not valued more highly than others, and that the interventions that are being taken, how can we make sure that we are considering all of the side effects of these interventions. So in a funny kind of way, you actually have a certain kind of similarity between the lockdowns and the overuses of these pharmaceuticals in the Scottish clinic, which consists in you use certain kinds of, there's a problem, a health problem, and you use a certain kind of intervention against it, but the intervention can cause more harm than it actually does anyone good, right? And certain kinds of lives might be saved, whereas others are not saved in the process, actually harmed in the process. And to develop some sort of much clearer understanding of how this might be happening and why this might be happening, I think this is the really important thing. And I still see probably too little of that, right? Particularly also when people are advocating that, of course, there must be a lockdown. Of course, we're gonna shut everything down because this is so vital for saving lives. But that there's this notion which is still there that maybe what we're doing is actually causing more harm, and probably not in the UK, because again, our fridges are full, the supermarkets are still there. But in a country such as India, I do think there's a huge question, and I've not even started talking about the civil rights aspects of this lockdown, where critics of the government lockdown are being put into prison. There's some terrible, terrible things are happening in India at the moment in the name of fighting the pandemic, right? Which also have to do with, I know from friends who've been writing about Muslim areas in cities being policed really badly and aggressively because there's this notion that Muslims are more to blame for the spread of the virus than others. So you have some terrible things happening, and I think that's just very little consciousness of any of that happening, because the attention is so focused on our own lives also at the moment that we're not seeing quite as clearly what is happening elsewhere also. And that, I think, should be, that requires also, that's why I think that the anthropological perspective is so important, and why the these blog series that have come up, which are specifically also looking at, okay, here's the experience and the unfolding of this pandemic in Borneo and in Java and in somewhere in Chile. This is actually extremely important to take this into consideration, sort of the far out knock-on effects of both the health policies that are being enacted here, but also the economic policies.
Yeah, I was going to say, that's precisely one contribution of anthropology, this kind of comparative view, which can help us, to kind of provincialize our own experience and, look at it in a way which is perhaps more critical. But thank you very much, Stefan. That was really fascinating. And I will now open the floor to questions from the audience.
Thank you.